A sudden catastrophic biological failure can occur in an otherwise physically prime young individual. Blood rapidly bottlenecks in an artery, showing zero signs of physical aging, triggering a fatal event long before any symptoms appear. To evaluate the danger of ASCVD, atherosclerotic cardiovascular disease, which is the buildup of cholesterol plaque in the arteries, clinicians typically rely on standard population-based probability models, such as the Framingham risk score. These legacy calculators operate with a heavy chronological bias. The algorithms explicitly weight advanced age and traditional lifestyle factors, like a multi-decade history of smoking or obesity, as the primary drivers of disease. This creates a dangerous paradox for a 20-year-old patient. A young individual will frequently return a Framingham score indicating a less than 1% 10-year risk of a cardiac event, even if their arteries currently harbor advanced, lethal subclinical disease. This miscalculation is a systematic blind spot in traditional cardiology. The mathematical formulas simply lack the inputs necessary to account for a concentrated genetic architecture passed down through generations. Age-based population calculators are effectively blind to the hidden risk within heavily gene-dosed young patients. There is a specific clinical threshold that demands an immediate deviation from standard protocol, a family history where a sudden cardiac death or myocardial infarction occurs before the age of 15. In the presence of these extreme premature events, the family tree ceases to act as a marker of statistical susceptibility. It provides sufficient diagnostic evidence to bypass formal sequencing. Specific physical anomalies powerfully signal the presence of monogenic mutations. For example, tendon xanthomas, cholesterol deposits under the skin, in a parent or sibling, have a near pathognomonic relationship with these variants. When you correlate that physical evidence with extreme lipid thresholds, the probability becomes near certain. An LDL-C measurement exceeding 190 milligrams per deciliter in a child from this family carries a 98% positive predictive value for the disease. For hereditary arrhythmia conditions like long QT syndrome, an inherited disorder affecting the heart's electrical system, unexplained historical tragedies in the pedigree, such as sudden infant death or drownings, are more reliable markers than modern EKGs. Up to 12% of mutation carriers show a completely normal electrical interval on a standard readout. When fatal events occur before age 15, the clinical phenotype is a deterministic surrogate for monogenic sequencing. The family tree is the test. The severity of these clinical phenotypes is governed by the gene dosing effect in Mendelian genetics. The total number of mutant alleles an individual inherits dictates the exact degree of systemic failure. This chart shows how familial hypercholesterolemia impairs LDL clearance across 3 distinct genetic states. In heterozygous FH, the patient inherits one pathogenic variant, leaving 50% of receptor function intact. This single dose doubles plasma LDL levels from birth, leading to premature coronary heart disease in the 50s. The third column represents homozygous FH, where variants are inherited from both parents. Receptor function plummets below 2%, causing an extreme spike in plasma LDL. The clinical reality of the double dose is catastrophic. These massive LDL elevations frequently trigger fatal infarctions before the patient reaches 15 years of age. This gene dosing concept extends beyond lipid disorders. It applies equally to hereditary arrhythmia syndromes. In certain founder mutations, we observe a dominant negative effect. A single mutated allele actively impairs the function of the wild-type protein alongside it. This interference effectively mimics the double-dose phenotype, driving the risk of a first cardiac event by age 15 to 74% in males. Inheriting a double dose of genetic failure acts as an exponential multiplier of mortality that drastically compresses the timeline of the disease. This dynamic family tree maps biological dosing into epidemiological data. A single parent with premature heart disease increases personal risk by 74%. When both parents are affected, relative risk climbs to 2.26, and the probability of a homozygous genotype reaches 25%. That 25% chance makes the risk of a fatal event before age 15 nearly 100 times higher. Epidemiological data reveals that lateral connections provide a stronger predictive signal. Sibling history frequently outperforms parental history in risk assessment. This brother-to-brother anomaly occurs because siblings share 50% of their DNA, but they also capture the cumulative polygenic background of both parents. Furthermore, siblings share exposure to the exact same modern environmental triggers in early life, which their parents likely avoided at the same age. To accurately predict extreme risk, clinicians must look laterally. A brother's early heart attack provides the loudest alarm bell in modern cardiovascular prediction. The traditional, non-invasive gold standard for identifying subclinical atherosclerosis is coronary artery calcium scoring, or CAC, a specialized CT scan used to measure calcified plaque and reclassify borderline risk. However, CAC scoring structurally sails the young, heavily gene-dosed demographic. Severe familial hypercholesterolemia in youth predominantly generates soft, non-calcified plaque. Because this soft plaque does not calcify during the early stages of the disease, a high-risk young patient will often return a CAC score of absolute 0. This provides a dangerous false sense of security. CT angiography, or CCTA, an imaging scan using contrast dye to visualize both blood flow and all plaque types, is the mandatory adjudicator. It provides a comprehensive view capable of detecting this invisible, non-calcified burden. The 2025 COT-CAD trial demonstrated this directly. Using CCTA to identify soft plaque in young patients with a premature family history allowed clinicians to guide targeted intensive statin therapy that successfully halted plaque progression. In a gene-dosed young patient, the family history overrides a 0 calcium score. CCTA must serve as the standard imaging modality. This equation displays the inherited hazard coefficient. It converts the qualitative family tree into a strict quantitative metric. The core variables rely on the mathematical coefficient of relatedness, combined with the exact age of the relative's first event. The severity multiplier recalibrates a final risk assessment, heavily weighting events like myocardial infarction and doubling the score if the relative's death occurred before age 15. The gene dosing modifier aggressively scales the total output upward if the history features double parent or parent plus sibling combinations. The inherited hazard coefficient reduces a complex narrative of family tragedy to an undeniable mathematical threshold for immediate clinical action. Emerging research in KAD survivorship indicates that some individuals with a high gene dose survive into old age due to hidden protective loss-of-function variants that neutralize deleterious genes. Without confirmed protective variants, clinicians must enforce a strict stratification of intervention based directly on the gene dose history. The extreme risk protocol, indicated by a double dose history, demands mandatory screening by age 2 and the initiation of aggressive therapy by age 5. The high-risk protocol, driven by a single dose history with an event under 45 years of age, requires universal screening between ages 5 and 10, with statins initiated as early as age 8. We cannot alter a patient's genetic ancestry, but treating a rigorous family pedigree as the ultimate diagnostic test allows us to preempt the timeline of clinical disease, intervening decades before the first anatomical failure.